My job now is to talk about the actual procedural steps. There is going to be some repetition because you can't just kickstart the topic. So some points have already been made. First is the fact that we are really talking about the epicardial vessels, wherein we can do the fractional flow reserve and non-hyperemic pressure ratios. Uh, we are actually addressing, as was said, only 5% of the total coronary circulation, both in terms of intervention at present and also in terms of measurements. Again, there is a plethora of measurements that can be made, but what I'm going to talk about is the FFR, or the fractional flow reserve. We also have heard about the PDPA ratio. We understand that ideally, when there is no resistance across the vessel, the PDPA ratio should be 1. But when a stenosis is present, that is less than 1. We have also heard in details why the cutoff values are 0.8. And the second value for FFR is, once you've done the coronary angioplasty, you should ideally do a repeat post-PCI FFR. And if your values are less than 0.9, particularly 0.85, then it is an inadequate procedure and needs to be addressed. Also, what needs to be understood is that FFR accounts for the size of a perfusion area. So it's a common observation that the distal lesions, though they may appear more severe, they're actually, the FFR values are less. If you find two lesions which are almost at similar distance, but you find difference in FFR value, it only is a surrogate for the fact that there is a distal scar tissue and the normal myocardium distal to the vessel is less. And it is also accounted for by collateral circulation. So if you have similar lesions, one is collateralized, the other is not, then the one with the collateral value will have a higher FFR ratio. Now, talking of percutaneous coronary interventions, we understand that there are 2 points, as has been pointed out here. Over here, at point number 6, once you've done angiography, if you have intermediate lesions, that is one point where you do FFR. And the other point is after you've done the coronary intervention to see the adequacy of coronary intervention. That is another point where you do an FFR. This is because we understand that 65% of intermediate lesions and even 20% of severe lesions by angiography actually are hemodynamically insignificant. And post FFR optimization is needed in almost 1 out of 3 patients who undergo PCI if you do a post-PCI FFR. And these are the benefits. We know that 35% of the times the angiography is inadequate, and there is a 35% reduction in death or MI if you use FFR. Now, these are the physiological steps which are required. So you start with flushing and zeroing the pressure wire. You further go and insert the pressure wire to the tip of the guide. You remove the introducer after the pressure wire has been introduced. You advance the pressure wire thereafter distal to the target lesion. You measure the resting physiologic index. And thereafter you measure the hyperemic FFR. And further, you go ahead and pull back, and you also check for things like the drift. This is a typical FFR setup. So you typically have the analyzer for the FFR, and you have an infusion pump to give the vasodilator, that is adenosine, which is most commonly used. This is how the pressure wire would typically look like, and the red arrow shows that is the point where the transducer is to measure the pressure. So the first step, as I said, is to zero everything. You got to keep the transducers at the level of the heart, and we have to flush flush the wire first and make it lie flat. So that's the first step. You're preparing the pressure wire by flushing, and after that, the zeroing of the system is done. Thereafter, the pressure wire is connected to it is put onto the guide wire and taken to the mouth of the Y connector. Thereafter, before we do that, on the pressure wire also we zero the system. Thereafter, the pressure wire is introduced into the guiding catheter, and we go up to the tip of the guiding catheter. We need to remember that at this point we need to equalize the pressures. Of importance is the fact that we need to take care of the fact that we should not have a residual contrast in the guiding catheter. We need to remove the introducer needle at this point of time, and if there are osteal lesions, then we need to disengage the catheter and take our measurements. If we see this particular point shows that the the pressure transducer should be just beyond 2 to 3 centimeters beyond the tip of the guiding catheter. Once that has been done and the pressure thereafter, we normalize the pressure wire at this stage. We cross the lesion, and after that we cross the lesion, and thereafter we take the resting measurements, and after that we give the hyperemic agent, that is adenosine most typically. The important point at this time is that we need to be sure that the pressure wire is not in contact with the vessel wall. In addition, thereafter we need to give adenosine. Typically, if we are giving it intravenously, it should be given in a dose of 140 micrograms per kilogram per minute. And if we are giving it intracoronary, then we give 200 micrograms of adenosine for the left coronary artery and 100 micrograms for the right coronary artery. And typically, adenosine almost always works very well. And there are few cases, however, where you achieve submaximal hyperemia. Thereafter, we need to pull the wire back, and we need to verify that the pressures equalize, and that is how we go ahead and get our FFR values in the hyperemic state. What do we need to watch for? We need to watch for the moving aortic transducer. Sometimes it just happens that the transducer is moving and it gives us a false value. If we forget to remove the needle, then we can have movement because of the needle itself, and it will depend upon whether we are using too thin a needle or too thick a needle. We also have to be aware of true gradient versus a signal drift, and this is important because this would not give us the accurate measurement. And we always need to check for the drift in the pressure after we've measured the FFR. In addition, the point that was just made, 2 days ago, one of my residents did an angiography, and he said there is an osteal left main lesion. That was because the left main had gone into spasm and it had gripped the catheter. Now, if we do resting measurements in that scenario, we will get false value if we do an FFR in that value. That is the reason I would agree with Dr. Murli that in all cases, hyperemia must be tested. Now, over here, if we find that our guiding catheter is deeply wedged, then we need to pull out the guiding catheter, disengage it, and check it again. Again, to highlight that wedging of the guiding catheter is one major source of false readings, and that must be taken care of. Uh, this can be made out by the fact whether the dichrotic notch is present or not. Sometimes there is a whipping movement of the wire, and that can also give us a false value. There are special scenarios. So if you have a typical aorto-osteal lesion, we need to disengage the guiding catheter. If it is a left main lesion, then we need to measure the pullback from both the circumflex and the LAD. And if there is a discrepancy between the rest and hyperemic gradients, you've got to make the clinical judgment. The scenarios where it is not really recommended is acute coronary syndromes. We are all aware of that. Saphenous vein grafts, again, it has not been found to be very useful. If you have serial stenosis, then during the pullback, we see where is the maximum step up, and that is actually the culprit lesion. Again, in a diffuse disease, if you don't get any significant pressure rise on the pullback, then it is a diffuse disease, but it helps us to also identify the culprit lesion. One important area where it is important to realize that we need to do FFR is when we find that there is a significant stenosis of the side branch. What has been seen is that only 1/3, or rather 19 to 20% of the side branch lesions which appear to be very significant are actually significant on FFR, and that has a great implication on our bifurcation interventions. I thank you for your kind attention.